the Director of Policy here at the Fund, and I'm delighted to be chairing today's session and to be joined by such a high quality panel. I'm just going to, before we get to hear from, bear with me just one moment, something is going wrong with my setup. Here we go, that's a good start. So I was just going to go through a few housekeeping points before then turning to our three excellent panel members to really get us going with some of the discussion of substance around the Queen's speech, and then we'll be opening up to questions from all of the delegates. So in terms of some of the housekeeping, a few bits and pieces, so bear with me whilst we go through this. The first is to say you are very welcome to tweet throughout the event. If you do want to do so, the hashtag is #KFIntegratedCare. Once we've got through the panel contributions, we will be moving to questions from the floor. We'll be using Slido to manage those questions rather than the chat function in MS Teams. So if you do have a question, please go to Slido. The detail of how you can do that is in both the chat and on the slide. But as a brief reminder, you can go to Slido, the website. You then need to just put in a code, which is KF Integrated Care, and that will get you to the questions. A couple of things about how then Slido works. If you really do want to do an anonymous question, that's how Slido defaults. I hope that we're a kind of community of colleagues that many of you will want to actually put your name to your questions and your name and organisation. So please do that if you feel able. And obviously you can also vote for other people's questions as well as putting your own questions, and that will help me pick the questions which are most popular amongst our virtual floor. So please do that. Please do not put any questions in the chat. I will not be looking at the chat for questions. I'll only be looking at Slido. So if you want to have your question heard, that's the way to go. A few other bits and pieces on housekeeping. We are on the record today, and the session is being recorded. It's being recorded just to share with people who were invited but unable to attend this morning. So it's not an open invitation for everybody, but just to reaffirm that you're joining instructions, and by joining today, you are giving permission for the session to be recorded and your contributions to be recorded. And I should also let colleagues know that there are a number of journalists who we are expecting to attend today, and actually I've seen a number of them were waiting in the lobby room, so we definitely have some journalists in attendance as well. So again, so people are aware when they're making their contributions. So I think that's all of the housekeeping for me. It's kind of quite a change where you don't have to talk about fire escapes and where the toilets are. That's all your own responsibility this morning, but still a lot to go through. So again, the very final piece of housekeeping, if people please, as participants and delegates, mute themselves, will improve the overall audio quality for all of our delegates this morning. So if you can make sure you're muted, that'd be really helpful. Thank you very much. Great. So I'll now move on to the more of the substance of today. So we're really delighted to welcome you all to join us today to talk about the Queen's speech and what the new parliamentary session will mean for health and care. We're joined by an absolutely great panel. We have Marie Gabriel, who wears many NHS hats, to give her perspective of what the expected health and social care bill will mean for working in the NHS. Richard Murray, the Chief Executive of the King's Fund, will give the Fund's perspective of what's in the Queen's speech for health and care and also what's missing. And then finally, Isabel Hardman will reflect on some of the politics of all of this and what we might expect to see as the bill starts to proceed through Parliament. So hopefully 3 really interesting perspectives, and we'll then come to Slido to be able to get some of the input from you all as participants and delegates today. So with no further housekeeping from me, I will hand over to Marie to go first. So Marie, as I've said, you have many different NHS roles. So I think you're in a unique position really to bring lots of that together to think what does the bill mean for the NHS? How is it going to really help what the NHS is trying to do day in, day out? How will it benefit patients? So over to you, Marie, and thank you very much for joining us today.
Thank you very much, Sally. And for those who don't know me, I'm Chair of North East London Integrated Care System. I'm chair at Norfolk and Suffolk Foundation Trust, which is a mental health trust in the east of England, and I'm also the chair of the NHS Race and Health Observatory, and have a role in terms of the National People Board and the London People Board. So yes, lots of different hats. And I've been asked, as Sally said, to give the NHS and ICS chair probably perspective, as well as the chair of a provider organisation. And I do believe, with all those different hats on, that the ambition within the Queen's speech is as expected by all of us. But actually, more than that, it's actually, I think we are agreed that it's the right ambition. It is right that through integrated care systems, we focus on improved outcomes, reduction of health inequalities in access, experience and outcomes, that we look at the wider determinants of health through the changes to public health, whilst retaining a local focus within that public health, and that local focus is a foundation stone, for the integration of care. It's also right, of course, that we maximise value for every NHS pound that is spent. And after all, it's not our money, it's the public's money, and it needs to be spent wisely. The ambition is right to ensure that we have a permissive culture where a national framework sets clear expectations whilst removing the competition that we've had previously, and instead requires us to collaborate. And for the national arm of the health service to ensure that we have system by default. So those people, as we say in the Caribbean, who feel it, know it, are the ones that are working with their partners, including their local communities, to deliver it. The ambition around retaining clinical leadership and being resident and patient driven is not to be argued with. Neither of the changes to the proposed Mental Health Act, which seeks to strengthen patient voice and choice, and the new Office for Health Promotion will be really good if it truly is able to influence policy across government so that prevention is rooted in the wider determinants of health. But of course, there is a however from me. There really is a need, we really feel it within the NHS, to recover, to regain ground by addressing waiting lists and increased demand, and to continue to deliver with a workforce that is exhausted and stressed. And we had the report yesterday from the Health Select Committee around the dangers of burnout, the numbers of people saying they want to leave the NHS, and the gaps that we had prior to COVID in terms of our clinical workforce that still need to be effectively addressed. Those feelings of exhaustion and morale actually include the leadership of the NHS that will be expected to ensure that these changes happen effectively, inclusively and productively. And this is actually more than the governance and design frameworks that we're expecting, and even more than the enabling legislation. This is actually about relationships, about doing things differently together, an approach that is hard for legislation to secure. And for example, in North East London, we know that we will have a sort of standard operations and assurance framework, but we've actually been working on what would our principles be for mutual accountability? What would that framework look like for us if we really are going to reduce health inequalities and really improve outcomes and experience and access? And we've not chosen to spend lots of time on governance around provider collaboratives. Rather, we've said, what's the work programme? So we, for example, we've asked our two mental health stroke community health organisations to look at out-of-area placements, and as a result, we actually don't have any mental health out-of-area placements in our patch. I will, of course, refer to the money. The additional investments we have received are welcome, including the non-recurrent funding, but of course that's a challenge, it is non-recurrent, but we have existing problems. The core public health grant for local government is still lower in real terms than it was in 2015-16. In mental health, we know the pandemic has had a significant impact on people's mental health, and that's going to continue. And one model suggests that over the next 3 years, there'll be 11% increase in referrals per year, costing between 1.1 and 1.4 billion pounds extra. There's also what we're finding in NHS, a really challenging role of balance that we will need to achieve. how do we ensure we have the investment in place and actually sub-place where our PCNs sit to achieve the prevention and health equity ambitions, while actually ensuring that our acutes have the resources to address.
How are you?
Sorry, how will we ensure, it's not me, how will we ensure that we retain a strong and engaged primary care with the demise of CCGs? And as a mental health chair too, I must highlight the need to ensure parity of esteem and an equal voice for mental health, and I actually would say community health services too. And I'm really concerned that the reforms aren't adequately addressing the needs of social care. I will finish by addressing a concern that is often highlighted, which is about the timing of the reforms. And, whilst ambition and potential are right, announcing the changes to Public Health England in the middle of a pandemic, I viewed at the time as a very risky strategy. And asking a workforce already exhausted and continuing to grapple with a pandemic to oversee the biggest change to the NHS in a decade is a really huge ask. But the truth is, I also asked myself, if we aren't collaborating, if we're not focusing on prevention, if we're not harnessing the clinical leadership and resident participation, how else will we overcome our current challenges? Thank you, Sally.
Thank you so much, Marie. A huge amount covered there in just 5 minutes. It's amazing. And I think a couple of the key things I'd draw out there is legislation can only go so far. This is about relationships and behaviours and culture. So legislation can get in the way, but it certainly can't make that stuff happen. So that kind of the people challenge of making this work is really important. And then the timing question, of you can see it as a distraction, or you can also see it as the only way to tackle the very stark challenges that we know we have across health and care. So that's absolutely great. Thanks, Marie. Just before I hand over to Richard to give the King's Fund perspective, just a reminder to colleagues to mute themselves if you're a participant, so we can make sure we hear all of the insights from our panellists. And please, any questions through on the Slido #KF Integrated Care. So again, we can start to quiz our expert panellists later with some difficult questions. But thank you, Marie, and over to you, Richard. Thank you.
So thanks, Sally. Thanks, Marie. I'll try and avoid repeating things that Marie has said. So just an observation to begin with. At the moment, we have a Queen's speech and we have a white paper and we have policy documents from NHS England. We don't actually have the bill itself. And so just a slight pause to make sure, I'm sure we'll all need to do, that the things that are in the white paper that we agree with, integration, population health, actually then do appear in the bill when it makes its almost imminent appearance, we expect. So 2 observations then about the legislation itself. One is, I think, to give them credit, both NHS England and the department are trying to do something different. So if you stand back from the way they hope the NHS will be working with its partner organisations, you have work going on at neighbourhoods, a lot of work going on at place, so often on a local government footprint where a lot of the heavy lifting of that integration, and then the integrated care system that will bring together, again, those partners in a more formal structure, and then new provider collaboratives being formed as well. And we saw only just recently Greater Manchester handing over a lot of money to those new provider collaboratives. But if you look at the white paper, it only really talks about the ICS. These other elements won't have a backing in legislation. So you have a piece of legislation that moves some of the pieces, but it leaves an awful lot to later guidance, to that work around cultures, to the work of local leaders to make it effective. And of course, to some extent, will leave quite a lot to the new Chief Executive of the NHS and the Secretary of State to decide, because it won't be set out in legislation. There is a tightrope being walked here between I think a desire for some for greater clarity, tell us what to do, a whole generations of NHS leaders having grown up with at its worst being told the decisions were for theirs to be made, only to be contradicted later by a national diktat. So a tightrope between giving as much scope for local discretion, for local leaders to be able to adjust the way that they work in the light of their local circumstances. East London, for example, is not the same as Cornwall. You would have to do very different things, different communities, different structures, different populations. So I think many of us think that that's the right way to do it, but you can't go too far. The NHS spends an awful lot of money. There needs to be some structure there, some weight-bearing structure that provides some governance, some accountability, some transparency of how that money moves. And there's a tension between those two. At the moment, certainly, we think from the white paper, the emphasis will be on that local discretion. But as Marie said, how much then gets left to local leaders, to subsequent guidance to sort out? And really, the legislation is only the starting pistol of the kind of round two of all of that work that's been going on. And I think, as one of our speakers here has once before said, if you thought competition was hard, try collaboration. And so all of that is to come. I think the other piece I'd pick out is, I think, like many people that will have read the white paper, slightly surprised how often new powers were appearing back with the Secretary of State. And again, I think this is something many of us are going to want to see. So a power to direct NHS England, powers over reconfiguration, powers over other arm's length bodies, powers over professional regulators. A real definite theme running through this of a movement back towards the department and back towards the Secretary of State. Of course, the world isn't the same as it was in 2012. Some of these structures do need to be looked at once again. But I think for most people, having the Secretary of State intervening in clinical decisions, in operational decisions, is probably not helpful. So it's one of the areas I think many of us will be looking at the detail of the legislation when it comes up. Then a couple of things I think that are potentially missing. Marie can speak very articulately about the benefits to the population, about population health, about integration. Some of that really isn't quite there in the white paper. It's a slightly more technocratic document. And the stuff of changing competitive procurement and the rights of delegation between foundation trusts is not the stuff that will set the heart beating more quickly for many people in the service. So we do need to keep that core narrative about why this is going to help patients. I think it makes sense to many people that are working in the service that have been trying to work around integrated care, but not necessarily to a wider audience. And we've also, as we've spoken with parliamentarians and others about the white paper, quite often what comes back is, what will it do for waiting times? Will this help me get to see my GP? And the answer is, well, largely not anytime soon. This is a technocratic piece that will alter the way the NHS works with its partners. For that wider benefit, for recovery, you need a properly funded plan. You critically need a workforce plan that stretches out from now over the years ahead to deal with the really deep workforce shortages. This is not really criticism of the white paper. It can't do, or the legislation, it can't do that. But if you wanted a rounded and comprehensive approach to trying to deal with the challenges of health and care in this country, you need that broader piece that will deal with the workforce issues and think about what we're going to do in a pragmatic way around waiting times. And then finally, the last two missing pieces. Outside of the legislation, we did get the new proposals for public health. So, as Marie said, to abolish Public Health England in the midst of a pandemic. I think if you were being Sir Humphrey, you would say a very brave decision, Minister. We'll wait until the final public inquiry to see quite what impact it had. But nonetheless, public health is absolutely key. Its skills, its functions, its abilities. And so we need that change to be absolutely alongside what's going on in the NHS, local government and partnership working. And then, of course, the gap that is so big, are waiting for proposals. And haven't we all grown old waiting for proposals on adult social care? So if you did want to improve access to adult social care, deal with the challenges around adult social care, this white paper legislation can't do it. That's the great missing piece around a government's ambition to improve health and care in this country. And that's, again, what we hope, and I won't say more than hope, will come out over this Parliament. So a lot then left for local leaders to make all of this work, but also for national leaders to fill in the bits that aren't quite there yet. Sally, thank you.
Great. Thank you very much, Richard. So some really important points, again, reinforcing that thing that this is although it's a technocratic change on paper, it's a big behavioural change, and kind of how how the balance of different behaviours come out in reality will be interesting. And on social care, one of those classics of I have considerably more grey hair now on social care than I did when I first got engaged with it, and I very much hope that I don't have many more grey hairs before we start to see some plans from government. But yes, it's clearly a big missing piece at the moment. I'm now going to move to Isabel for our final panel contribution before then coming to questions. I will just remind people to put questions in Slido. We appear at the moment to have a somewhat shy King's Fund audience, which is very unlike you guys normally. So please don't be shy with questions. There's no such thing as a silly question, so please do ask away. But Isabel, you're going to give a bit more of the kind of the hard politics perspective on what this might kind of be like as it's going through Parliament, what some of the issues and challenges might be. So over to you, Isabel. Thank you.
Well, thank you so much for having me at this event, and thanks for the other two speakers who've been really, really fascinating. And your point about grey hairs on social care, one of my first assignments as a junior reporter in 2009 was covering Andy Burnham's social care proposals, and I'm starting to worry that it may be, as I'm approaching my own retirement, that we get the solution to social care that I'm actually able to write about. But in terms of the hard politics of this, I think there's a sort of anxiety-inducing lack of anxiety in Westminster about two things. One is the waiting lists. There's obviously an awareness of the NHS backlog, and it's raised a lot in departmental questions and occasionally at Prime Minister's questions. But I don't think the public have really appreciated, MPs have really appreciated, and particularly Conservative ministers have appreciated the political impact on the public of these long waiting lists, of these individual stories of people who die while waiting for treatment, who could have expected to have been treated within a couple of months, who are waiting for 12, 18 months and so on. I'm not sure they've quite appreciated that, because there seems to be a lack of panic about that and a complacency about how much is being done at the moment. And as anyone in the health world knows, that there is not a plan to deal with the backlog at the moment. But ministers seem to think that if they just sort of talk vaguely about pots of money that they've already allocated that haven't even touched the sides of the NHS so far, then they can sort of claim that they're already dealing with this, which I think is worrying for those who realise that, well, even from a political perspective, if the Conservative government isn't dealing with this problem now, then it's going to be a hell of a row when it comes to the next general election, whenever that is, whether we have a slightly earlier general election in the next few years or not. It will be too late for them to start throwing money and announcements at the problem as they go up to polling day. I think the second lack of anxiety and worrying amount of complacency is about this legislation. I think generally in Westminster, the understanding of the legislation is that it is a tidying up and unpicking of the more problematic parts of the Lansley legislation. And while that is true, it obviously goes much further than that. And the points that Richard made about the powers of the Secretary of State, I don't think have been at all appreciated by MPs, who have largely sort of filed it in the "this is something I'll just do as the whips tell me on" box. I think that that's going to become much more of an issue in the next few months, not least because if you had a Secretary of State who wanted to give himself more power, you probably wouldn't start with Matt Hancock in the current position that he's in, where he doesn't have very much political capital. And so for him to be arguing to MPs, I need to be more powerful, that's quite a difficult sell at the moment. He doesn't have that many fans within his own party, let alone across Parliament. He hasn't explained why he needs certain powers of intervention much earlier than the Secretary of State has at the moment, why he needs to be involved in the level of detail that he seems to be wanting to give himself in the legislation. And so far he's largely got away with that because people have focused wrongly, in my view, on the line from Simon Stevens that most of this is what the NHS wanted, but Simon Stevens has always had a gap after most of, which is where he's very clear by omission that there's quite a bit in there that the NHS didn't want, and that's where the political row is going to end up being, I think, within the Conservative Party, let alone in Parliament more widely on some of the issues around competition and so on. I think there's also an important context with the Treasury here, which is which we've obviously seen around social care, one of the key reasons always for delays in social care is that the Treasury suddenly goes, oh my God, this is going to cost so much money. But I think we have specific circumstances here, not just with Rishi Sunak worrying about the amount of money, but also with the Chief Secretary to the Treasury, Steve Barclay, who is very sceptical about demands for more and more money from the health service, let alone the possibility of setting up a second taxpayer-funded, free at the point of use care service. Steve Barclay was obviously a health minister in the past before he went to the Treasury, and that has really shaped his view of the NHS, but not necessarily in a way that is particularly beneficial to the health service. He was, I think he formed a view of a health service that is largely a sort of plug hole down which you pour money and you don't necessarily see anything back from that. And given that Rishi Sunak has not had any experience as a health minister, he largely gets his opinions on the NHS and on some of the demands for spending from Steve Barclay, which again means that there's not a health department spy in the Treasury at the moment who's sort of saying, here, we actually do need this money. Politically, this is going to cause us a problem when we have, even worse waiting lists, even worse anecdotes of people missing treatment than we have at the moment. So I think those are the main political problems. A couple of things that are missing, I think, from the conversation again around the white paper that were mentioned by others, the lack of measures on workforce, and I think it was that the Health Select Committee report this week was really important on that, but it was slightly strange hearing from a Secretary of State who did have the opportunity to, a former Secretary of State who did have the opportunity to introduce workforce planning, Jeremy Hunt, but didn't. Now his argument is obviously that the Treasury blocked this and said it was a spending review decision and that it never happened. But it just highlighted the fact that for a very, very long time, ministers have put off proper workforce planning, and I'm not entirely sure that the mood in Westminster at the moment is in favour of better long-term workforce planning either, given the other pressures that are circling on all sorts of different spending priorities. I suspect that one of the sort of political distractions that ministers may try to engineer to show that they are serious about tackling waiting times and serious about getting the NHS back to normal is a standoff with GPs over remote appointments and whether or not they should be seeing their patients face to face as a matter of course. We've already seen the BMA taking a position on that, which I think may be quite convenient for ministers, because then it looks as though they are fighting reluctant doctors who don't want to see their patients, and you can just see the way in which that battle can be manufactured in the press. And obviously it's something that the public always pick up on, because their relationship with their GP is often the way in which they perceive the NHS. So I think it's worth keeping an eye out for that. So there's a lot of rows coming down the road, but I'm not sure many MPs have noticed that they're coming yet, which is strange because that's exactly what happened with the Lansley reforms a decade ago. And one of the reasons that the Conservatives haven't done any legislating on the NHS for a decade is that no one saw the row with Lansley coming. Then suddenly it blew up and everyone was very upset by it. So it's going to be a fun few months.
Great. Thanks very much, Isabel. So there is despite an 80-seat majority, there's definitely a risk that we have as bumpy a parliamentary process as we did just a decade ago, because it was a decade ago we'd just come out of the pause to restart the bill. So thank you very much. We are, I'm going to mainly take questions from Slido, but there's a few people where I just wanted to bring in, partly so you got to see some different faces and hear some different voices on some slightly different perspectives. And the first of those is Paul, who I know can't stay with us for the whole session, so I'm cheekily already keeping him a few minutes beyond what I'd agree. But Paul, I wonder if you could just give your perspective from a local government point of view about the opportunities and challenges of the reforms, and we'll get some of the panel's take on that as well. So over to you, Paul, and please do introduce yourself to attendees who might not know you. I'm sure they do.
Thanks, Sally. And it's great to be with you this morning. I'm Paul Nysarik. I'm Chief Executive at London Borough of Ealing, and I also lead for the Society of Local Authority Chief Execs on health and social care. So great to be with you. I think the panel have been stellar as ever. So I'll only try and add a little to what colleagues have said from a local government standpoint. I guess from local government view overall is we welcome, I think, the majority of what the bill is likely to cover. I think but picking up the point a number of panelists have made, I think we welcome the narrative and the mood music even more, if you know what I mean. So, but the narrative and the mood music isn't totally covered in the bill. So for us, the test will be what really happens in practice, especially in the areas where the bill is likely to be silent, I think. So I think that point around culture and how we work is going to be incredibly important, and therefore follow through on this and implementation is going to be key. On a couple of specifics, clearly from the point of view of places and the point of view of local government, the ICS, the integrated care system, is not devolution. So it's going to be really important, we're never going to get to a world where all of this gets perfectly joined up in Whitehall, and we're unlikely to get to a world where everything gets joined up in the ICS. So we've really got to keep up the pressure for this to be a genuinely devolutionary piece of work and project. So I think that's an important area we need to keep an eye on. In its own right as well, this is not, as a bill, going to tackle inequality and going to focus on population health management. It might enable us to do that, but it won't necessarily do that on its own. So we've absolutely got to keep up the focus in the way we work to make sure we address those issues. I think, Sally, we've talked a bit, and I really take this seriously, about the risks that the bill ignores waiting lists or doesn't address waiting lists. I think there's also a kind of opposite risk, which is that all we end up doing for the next couple of years is focusing on waiting lists. And that will mean we don't deliver on the narrative and the mood music that we all want to address as well. So I think we need to keep that balance in view, Sally. And probably my last point, just in the interest of time, would be, I can't not reinforce adult social care. We've got a major package on the NHS. We've at least got the start of a significant package on public health, although it's largely focused on the national level at the moment. But we don't have a package on adult social care, and I think that's probably the point I'll finish on, Sally, is we need social care, public health, and the NHS reform to work in a coherent way. And at the moment, the package we have is partial, so we need to fill in those blanks. Indeed, on social care, there are one or two clauses in the likely bill about social care, but they're about assurance. So I'm not saying that's not an important conversation, but it probably wouldn't be where I'd be starting the conversation, Sally. So thanks for the contribution, for the opportunity to contribute, and really look forward to the dialogue. Thanks, Sally.
Thanks very much, Paul. So I think there are particularly some reinforcing the points about what's missing in the overall reform space, some important bits about actually a real focus on population health and health improvement, requiring a very different way of thinking and working. So this feels like it links quite well with a question we've got from Adam Sewell-Jones. So I'm going to kind of put Paul's thoughts and Adam's questions to Richard and Marie. So Adam's question is, how do we stop the NHS system and those of us working in it spending all of its time and energy focusing on legislation and the traditional metric chasing rather than on the things that can make a health difference, such as housing and local regeneration? I promised Marie that I'd give difficult questions to Richard first off, because Marie's been working all night long. So I'll go Richard first and then Marie.
So I think where the proposal started was an attempt to try and keep the scale of the change down, so that it wouldn't be, I think it was David Nicholson called the last one, the NHS reorganisation that could be seen from outer space. I fear that's going to be difficult to do. These reorganisations do cause a lot of effort, and I think some people are already dusting down their CVs to try and make sure they have a post in the new system and new structure. So I think alongside all the other work that's going on, still trying to pay as much attention to actually some of the slightly technical details about HR, so that we can reduce the pain and pressure on people from a reorganisation. And I think NHS England started at that place, but I'm not too sure the effort's been continued. And you're right about the metrics. I think it does link to what Paul was saying. We can really measure waiting times very well for acute services. It's something you know, the United Kingdom may or may not be world beating in many areas, but we're pretty world beating on our measurement of waiting times. The problem is then it draws that focus down upon those waiting times, partly because they really do matter to the public. They can become an absolute hygiene issue if they get beyond a certain level. But I think also today, if you were to test the mood of the public, things around mental health matter. I think we've seen things around inequalities are difficult to express because I don't think the public necessarily thinking that way, also matter too. So to try and avoid a switch back to that very heavy-handed top-down performance management, the legislation won't stop. That hasn't. It's very difficult to take that away. I mean, the Lansley reform is supposed to have stopped that, and it didn't stop national bodies being able to do it, or indeed regional bodies being able to do it. But trying to have a wider conversation, I think that can be done partly through some of these structures by making sure patients and the public are part of this system. So they are there in the ICS, they are there in the place conversation, so that we can try and reflect back what the priorities are for local people, rather than a sect that just comes out of Whitehall. But it's business that still needs to be done. I don't think you can legislate for it.
Great, thanks, Richard. Marie, is there anything you'd like to add to that?
Yes, I would, and Adam, I was in your A&E last night, but we'll pick that up later. So I think what's really important is actually what do we measure as success as a system. So I was talking before about, you know, we've had the conversation on the you know, on the framework, the metrics that are going to be used to judge success, and of course things like waiting time and access will be in there. But really, in North East London, we've been developing a set of principles about how we would judge our success, and actually how do we make sure that communities and partners inform and set those measures, because I think those are the most important. I think exploring our role as anchor organisation is really key to this, and I think there's been a real move in the NHS to do that, and to do that well, and to focus on those wider determinants. And in North East London, we're being facilitated by Derek Feely, who ex-chief exec of NHS Scotland and Institute for Healthcare Improvement, and he was asking us to think, well, if you're going to work as a partnership, what do you want to work on? And the things that were coming out were employment, knife crime, housing, and learning disability. So they weren't actually health focused. And if we really are truly going to provide a health service that meets the needs and aspirations of our populations, waiting lists will be part of it, but it'll be the whole person that we will need to support together. Thank you.
Great, thanks very much, Marie. So I'm going to move on to a question around workforce, and then on to looking from a voluntary sector perspective, because there's a couple of questions around the voluntary sector. But on workforce, I think this question maybe to Isabel first, and then Richard might want to add. So a question from Sean Walsh saying, workforce shortages are not new. What's the hurdle stopping government funding the people plan? What's missing from the case we need to make to Treasury to get this over the line at the spending review? So Isabel, you talk quite a lot about the sort of the insider workings of the Treasury. So what do you think's missing? How can we help get this across the line?
Yeah, you're right, and you know, the NHS has struggled with workforce for long enough for it to have figured on politicians' radar by now. And I think the pandemic has made the penny drop, I think, in that it's now being talked about, which it wasn't before. So that's progress of sorts. But I think in terms of making the case, look, there is an issue, to come back to Matt Hancock. I think there is an issue with a Secretary of State who doesn't have that much political capital. If you remember, Jeremy Hunt basically managed to get what he wanted for the NHS because he'd been the longest serving health secretary. He'd been incredibly loyal to two prime ministers, actually, by the time he started making his demands. And he was in a really strong place to basically firstly say to Theresa May, I don't want to be moved, and also to get the money that he thought that the NHS needed at the time. Now, Matt Hancock really is trying to keep his job at the moment, and that's not a great position to be negotiating with the Treasury. So in terms of having sort of a champion in the department, I'm not sure that there really is one. That's not to denigrate his own sort of commitment to the NHS. It's just that the truth is that he doesn't have the political capital to fight with the Treasury, and to get long-term money from the Treasury is always really difficult. To get it at the moment where you've got competing demands on all sorts of things and temptations for short-term commitments that are more headline grabbing, I think, on the NHS than a sort of long-term workforce plan and the training of workforce into the distant future, which is obviously the case with a lot of positions in the NHS. I think that is going to be very difficult. The best way to make that case, I think, is through the stories that I mentioned. I was watching that excellent BBC hospital programme last night, and I'm a bit behind on it actually, but it really brought home to me again that the personal strain that the pandemic has wrought on a lot of people. To see an intensive care consultant in tears on the phone to a family who were about to lose the husband, their dad, I think those sorts of stories about workforce, about patients who have been affected by these delays, by these shortages, that's what makes politicians listen as much as anything else. And so to get those stories out there, I think, is the best way of making the case.
Great, thanks very much, Isabel. Richard, you've negotiated several spending reviews with Treasury, so do you have anything else to add to Isabel's contribution?
The only thing I'd say is Treasury can be portrayed as the bogeyman so often by any spending department, and I understand from Treasury, as I used to sit there and tell them that the lid would come off hell unless they gave me all the money they wanted. But unfortunately, I had education and defence on either side of me saying exactly the same thing, but for completely different reasons. So part of this, I would say, and it may be, given the position of the department at the moment, this is something that external bodies can help with, is if you're a government that thinks it's going to win the next election and be in power for quite some time, ignoring the NHS workforce will come at increasing pain and grief. You cannot deliver better services without the right workforce there. And I think that's partly why some of this appeared in the last Conservative manifesto, who attached themselves to a number of numeric targets on the workforce. And I think the last time we really saw a government have a long-term plan for the workforce was back around 2000. Exactly then, because the Tony Blair government did think it was going to be in power for quite a long time. And indeed, the success on the NHS was one of the things that helped them achieve that. So I think there's a real piece of self-interest and understanding, particularly in Number 10, but also in Treasury. They don't like making the wrong decision. And if the natural voice, the department, is politically weak at the moment, then I think others can help make it too.
Great. Thanks very much, Richard. I'm now going to move on to the voluntary sector, who are obviously an absolutely key partner to the NHS and local government and have been forever and a day. But I think particularly in the last 15 months with the pandemic, that kind of crucial connection has really been brought to the fore. So there have been a number of questions about how the voluntary sector can engage with ICSs, etc. But I was going to ask Neil Tester from the Richmond Group perspective, just to give his perspective about the opportunities and challenges from the voluntary sector. So no pressure, Neil, but you're speaking on behalf of the whole voluntary sector, so all very easy for you. But over to you, Neil.
Thanks, Sally. There's no way I would be daft enough to presume to do that. People can absolutely speak for themselves. Well, I think there is a really broad consensus across the sector and beyond it. And one of the things, as you say, sort of we've seen in the last year and a half is some of the scales falling from the eyes of people in the system, not about the importance of the sector. I think the system's always valued the sector, but a better understanding now of what the genuine strategic contribution is and could be. And so from the point of view of opportunities, I think not just the legislation, but the years of change and development that will come after it do present a real opportunity to get that change embedded. there's been some brilliant points from the panel about some of those key issues like workforce, health inequalities, the gaping social care gap. So I won't labour those points. I wanted really just to focus on two things. So one is something that I think relates to some of those political issues that Isabel talked about, that people may think aren't there, but definitely are going to come up to bite people. And it relates to Richard's point and some of the things that Marie said about public and community involvement and engagement, because we feel really strongly that there's an opportunity with this legislation to lock in some of the emerging really positive culture. You know, lots of pennies have dropped really since we started out on the journey back in the days of STPs. And a lot of furore about a lack of perceived consultation around that, to a shift to people really thinking quite strategically about engagement around ICSs. But we think that needs to be entrenched. So we're suggesting that the legislation could usefully include a duty for systems to demonstrate how public voice has shaped decisions and how strategies and plans and services have been genuinely co-designed and co-produced with the people that were affected, with wider communities, and with the voluntary and community sector partners that are going to be key to all of that. And then thinking about some of those issues that have been touched on around things like waiting lists, people's right to access to treatment, getting a bit geeky for a moment. Nobody ever talks about the mandate anymore, but the legislation isn't proposing to abolish the mandate. So it's going to stay there. It's just that it's not going to be updated as often. Well, if that's the case, that makes it even more important that there is proper and genuine public consultation on the nature of the mandate. The last time we had that was 2015. So I think there needs to be some proper debate around that. And also our members are really concerned to make sure that by accident we don't end up seeing this legislation rolling back some of the rights that are provided for in the NHS constitution. Know that it's a kind of dignified part of the constitutional setup, but nonetheless we wouldn't want to see that written out. And then the second thing really is about the strategic role of the voluntary community sector and the way that helps to strengthen public voice as well. So I think we completely get why people don't want to specify to the nth degree, you must have 3 people from this kinds of voluntary sector organisation on this committee. But I think the select committee a few weeks ago were absolutely right to press for a much more explicit role for public voice in the governance arrangements. And we think that could be strengthened further actually by thinking in a bit more detail about the voluntary sector contribution to doing that. We think there should also be potentially an extension to the duty to collaborate, to oblige systems to collaborate actively with the VCS, so that you go just beyond that sort of vague permission and into a really strong steer and strong encouragement. And then finally, just thinking about what the white paper says about effective data sharing between services, we think that could be strengthened to make sure that it's really facilitating effective partnerships with voluntary sector service providers who often just run into pointless barriers around data that the system has just tried really hard to spend 18 months dismantling, and it'd be a real shame to see those put back in again.
Great. Thank you very much, Neil. Really helpful reflections and challenges. I thought I might just come to Marie as the kind of panel member who's, I guess, trying to grapple with this reality day in, day about how do you create the right relationships, how do you have the right voices in the room, and to what extent that should be in legislation versus to what extent legislation really can't make that happen. So, Marie, just be interested to get your reflections from what Neil has said.
So, I mean, I think Neil's right. The role of the voluntary sector in terms of voice, in terms of delivery, in terms of being part of holding us to account and being a true partner in the room is completely correct. And what we've been doing in North East London is actually working alongside our voluntary sector kind of umbrella bodies and Health Watch to actually define what that should be like. So it's not right for us as an ICS to say this is what it should look like. It's actually how do we interact with that. And we know that the voluntary sector is beautiful in all its colours, shapes and sizes, but sometimes quite hard to navigate how as a health agency, how do you do that well. I think Richard, sorry, I forgot his name. Neil didn't sort of emphasise the delivery part, but I think with my provider hat on, working in Norfolk and Suffolk with Mind has actually delivering services and helping us manage waiting lists and helping us to keep people safe while they're waiting. It's a really key role that the voluntary sector play, and I would welcome a duty to collaborate, but also I think, as I said earlier, it's actually about the ambition and about the ways of working which you can't really legislate for. But I do perceive that duty to collaborate not to just be with local government, other NHS organisations, but also the voluntary sector in our communities. Thank you, Sally.
Great, thank you very much, Marie. Unless either Isabel or Richard want to jump in on that question, I was going to move on, if that's okay. Great. So I think we can obviously, we're all people on the panel and people in the audience who live and breathe the NHS in the most part. So we can very easily get into quite a geeky conversation about powers and systems and duties, etc. And as we've kind of touched on a bit throughout this morning, that might not be stuff that really floats the boat over much of the public. So I thought it would be really interesting to hear from Kate Duxbury at Ipsos Mori about actually what are the public worried about when it comes to the NHS and wider health and care services, and then maybe get some reflections from the panellists as a kind of final reflection about to what extent the overall reform programmes, not just the bill, but the overall ambitions may or may not meet those expectations and priorities for the public. So Kate, thank you very much for joining us this morning, and over to you for a few minutes of what the public really want.
Thank you, Sally. And I think that's a great point. And we know that people don't actually really care about structures. So I think Richard said it's quite a technocratic bill, and it is, and people don't care about structures. They don't know necessarily who provides services to them. So there might be a local authority funded care organisation going into their home providing care, and they'll just assume it's an NHS service. And that's because it doesn't actually matter to them who provides the service. What matters is that it's good. So I think as far as the legislation enables better coordinated care for people, then that's great, and that will filter through to patients. When we speak to them, we do hear things like having to repeat their history, the person that turns up at the door not knowing who they are and what their issues are necessarily. So if the legislation can address that, that will help them. But when you ask people about the problems facing the NHS, they don't talk about quality very much. Only about 5% of people say the quality of care is an issue. So actually, what they really are worried about is workforce. Half of people say that that's the biggest problem facing the NHS. And when you ask about their priorities for what they want the focus to be for the NHS, that's waiting times, routine waiting times, and also increasing the numbers of staff. So those are things that maybe fall a little bit outside of the bill that people would really want to be focused on. And I would endorse what's been said about involving patients and the public in deciding priorities at ICS and place level, also in the mandate, but also just to emphasise the importance of hearing a diversity of voice in there. So it's not the usual people, hearing and reflecting a wider diversity of voices. And then also, it isn't just about public priorities that you can hear through polling. It's elements that you flagged as being missing, like social care. Those aren't things that will come out in polling because, frankly, a fair percentage of people don't understand that social care isn't just funded by the state. And when you have qualitative discussions with people and you explain how the funding works, they're quite shocked, actually. So those types of things will never crop up in funding as being a top priority, even though they're very important.
Great, thank you very much, Kate, really helpful. So I'd be interested to get kind of final reflections from each of the panellists, I guess, on some of the challenge that Kate's talked about there. So if the public aren't interested in structures, and of course they aren't, really, why should they? But we're kind of lacking a really strong narrative that connects the white paper and the wider set reforms to what are the benefits, the real tangible benefits to the public and patients, and how they connect to their stated priorities. So just interested in your reflections about whether it's possible to create that kind of narrative, or the political kind of risks that get exposed by this kind of disconnect between the public concerns and what the current set of reforms do. So I think I might do the same order that we did the panel to start. So I'll go Marie, Richard, and then Isabel, if that's okay. Over to you, Marie.
Thank you. I actually believe that, and this is based on conversation with North East London with Health Watch around collaboration between two of our acutes, parts of BHRUT, about the legislation. They completely agree with what was just being said. So I think it's actually for us as ICSs to actually make the ambition around integration and reducing health inequalities real. It's, you know, the onus is on us to go out and have those conversations with our communities and with our publics, and actually to make participation interesting and exciting, and for that to really determine what our priorities would be. So you remember earlier on I talked about, you know, how will we measure success and how we need to engage our patients and communities to define that for us. And actually the voluntary sector are going to be our partners in helping to define those factors. And I think equality in terms of, you know, reducing those, but actually ensuring that those communities we don't often listen to are right in centre of that debate is extremely important. So I do think that it would be better if there was an improved narrative around the white paper. But actually, I think within the NHS and local government and the voluntary sector, we are developing that narrative. So it's meaningful within each of our regions. As Richard said, we're so different. The narrative in North East London would not be the same as Cornwall, but the overall ambition, I think, would be. Thank you.
Great, thanks very much, Marie. So I'll go to Richard and then Izzy with just a slight gentle reminder to my panellists about the time at the moment. So Richard, over to you.
Just to say, I think the reforms, if they do what they say on the tin about the things that Marie's spoken about, will be a good thing, but they're not enough on their own. I mean, the waiting times, and I'd also pick out mental health too, will hurt the public, and they hurt the country too. You need an answer to them about what you're going to do, and the reforms answer one set of questions which are incredibly important, have been with us for a very long time, but they can't answer those. How could they? Those have really magnified through COVID. And I think, just to pick out that point about the public really care about waiting times, they do care about access for mental health as well, I think, these days. And they care about the workforce. These are the same issues. You can't deal with access without dealing with the workforce. And I do remember when we did the NHS plan, I am that old, and you asked the public what they wanted most of all, with all the extra money, it was more staff. That's what they wanted. But I do think they understood that that would also improve their experience of the service and would make waiting times fall.
Great, thanks very much, Richard. And Isabel, the final panellist word from you.
Yeah, well, very briefly from me, just I think that the point about the shock when people find out about the funding and the cost of social care is really important to highlight. It's the key reason, along with the Treasury not wanting to dole out huge amounts of money, that politicians always panic about reform because people assume it's free, and then along comes a politician saying, "Here's my reform, and it's going to cost you lots of money," which they don't appreciate is already the case. I think also just on the legislation, remember that the Conservatives did the Lansley reforms because they felt they were in a strong place on the NHS, having basically got Labour into a bit of a sticky position by polling day in 2010. Now they only feel strong enough to do this legislation now, a decade later, because they've basically tried to let sleeping dogs lie for a long time, which I know has caused the NHS a lot of problems in terms of sort of pushing some of the limits of what can be done in the law, while working around some of the problems with the Lansley reforms. But I think there is an issue here, which is that if the Conservatives have another row about this, regardless of the impact it has sort of on voters' perceptions of the NHS, it does have an impact on voters' perceptions of what the Conservatives want to do with the health service. And I think that is a political issue for them.
Right. Thanks very much, Isabel. Really helpful. So we're now at 9:30, so I'm going to draw us to a close. So my thanks to Marie, Richard and Isabel for really insightful contributions throughout this morning. It's been absolutely fascinating to hear your perspectives. My thanks also to Paul, Neil and Kate for adding their kind of challenges and opportunities throughout the morning, and to questions from our delegates throughout the morning. I hope you've all found it helpful. In terms of next steps, I think the thing I will leave you with is Richard's point that we all think we know what's going to be in the bill, but we don't actually have the bill. So when it gets published, obviously it's all of our jobs to read it and check that what we expected is there. And from a King's Fund perspective, we'll provide some resources to help you all make sense of that as well. So please do keep looking out for King's Fund resources as the bill is introduced and then progresses through Parliament over the next few months. But at that point, I will say thank you all very much for joining us, and we hope to see you at further events, both virtually and fingers crossed in person, over the next few months. So thank you for joining us this morning, and thank you to our panellists for their time and contribution. Thank you and good morning. Bye.